I guess we'll start. We just have to wait for others so that we are on time. So good evening, everyone. And depending on where you are joining us from, I'm so excited for us to have the first virtual event for all the states. We've got all the states for ASCA members represented. My name is Agnes. I'm the founder and executive director of Australian Sickle Cell Advocacy. Before I start, I just want to acknowledge the traditional owners of the land on which we work, even if we're doing this virtually. So the program today will be pretty much what we sent because we want to be on time. All the speakers or the presenters will have to do self-introduction. We won't dwell into so much doing the biographies just because we want to be on time. So the purpose of this event is to acknowledge sickle cell warriors and anyone who's impacted by sickle cell disease globally. We do this because this day has been recognized by the World Health Organization. It was recognized in 2016 and the United Nations in 2018. It's held annually to raise awareness, to understand sickle cell disease and the challenges faced by all these people that are impacted. Today also, we would like to acknowledge that next week from the 14th to the 20th of June, it's World Blood Donor Week. And Blood Donor Week is an annual event usually on the same date each year to thank voluntary blood donors and acknowledge them and encourage blood donations and new donors. We have created a lifeblood team, which is called Australian Sickle Cell Advocacy. So every time you want to donate or your loved ones, please tell them to join our team so that we can do our part to raise awareness. So at this point, I just want to thank all the guests that have joined us today from all parts of Australia. We are thankful for taking your time being a Friday afternoon. And without taking so much of your time, I'll just hand over the floor to our chairperson, Dr. Margaret Evans-Scalia. Dr. Margaret Evans-Scalia, thank you.
Thank you, Agnes. That's really kind of you. Hi, everyone. It is a Friday night. I really, really appreciate you taking the time to join us. I know it's been a long week, certainly if you're based in Melbourne. But I'm Dr. Marguerite Evans-Scalia, the IMNIS Executive Director with the Australian Academy of Technology and co-founder. I'll just ask folks to mute if they can, please. I'm also co-founder of Women in STEM Australia, but obviously more importantly, I'm chair of ASCA, and it's a real honour to be in that role especially. It's a pleasure to welcome you here tonight. Thanks again for taking the time to join and celebrate this really important day of World Sickle Cell Day. I'd like to acknowledge the traditional owners of the lands on which we all connect today, wherever you are, and pay respects to elders past, present and emerging, as well as elders and representatives of any other communities who are and any Indigenous people online today. Tonight, we're Wurundjeri country and it's a little chilly in Wurundjeri country right now. I first met Agnes after an event back in November 2018. I was immediately moved in just one conversation by her passion and commitment to help not only her family living with sickle cell disease, but also others, many, many others. She wanted to help everybody, the whole world. I was really impressed by her commitment, and I was very inspired by her passion. So when she asked me to serve with ASCA, I just couldn't say no. Since then, it's been an honour and privilege to walk alongside Agnes and her executive team and to work with the board, a senior expert board of clinicians, researchers, scientists and professionals. And our goal has been to raise the profile of sickle cell disease in Australia, both in the clinical care, the education, as well as the research areas. So we focus on a number of different areas, but more importantly, to provide advocacy and support for those living with sickle cell. I think ASCA has, become a respected, influential voice. It is Australia's first charity solely dedicated to sickle cell disease. This is clearly a growing disease based on advice from our clinicians and the board within Australia's population. So I think it's a really timely and much needed advocacy group. In a very short time, working with the board, the executive has established support groups for people living with sickle cell, has a growing membership and fostered a real community around sickle cell disease community to share knowledge and advice, introduced online clinical education for healthcare providers, created an entire network of change makers and champions with all of the state-based ASCA chapters, and you'll hear from some of those tonight, engaged with leaders in industry research as well as state and federal governments. A lot of engagement has occurred and it's been very meaningful, and received funding through donations, sponsorships, as well as grants that they have applied for. So congratulations to the team on that. They've created internationally recognised talks with Agnes. I love that, Agnes, your Facebook talks, organised conferences and lighting up landmarks, you know, for World Sickle Cell Day. I don't know if everyone's aware, but buildings will light up this year again, and I just think that's marvellous. And most recently, a terrific achievement together with the clinicians on the ASCA board and Agnes and her team is the ASCA application for newborn screening of sickle cell disease has progressed to full review. And so, you know, kudos to everybody for making that happen. I think that's a real achievement. And we certainly have written to the Minister to thank him as well. But importantly, it's not just an idea. This is not just, you know, a small group of volunteers trying to achieve everything. This is a savvy group of professionals who are keen to see real meaningful change for people living with sickle cell disease in Australia. And we now have a 5-year strategic plan, a funding mechanism in place, and a budget to match it. And so it's obviously work in progress and it has a long way to go, but please embrace it and support it, because I think ASCA, you know, it has a huge amount of potential to really help people living with sickle cell. It's quite a list of achievements, and so you'll no doubt agree with me that it's something we can all be proud of and all get involved with. I encourage everyone to do so. I thank everyone who has been involved, including the board, my colleagues on the board, as well as the executive, as well as our ambassadors, members and volunteers. You know, it's just a pleasure change making with all of you, and it's been a real honour, so thank you.
Thank you so much, Dr. Margaret Evans-Scalia, and just thanking the team again for the achievements that we've done. We just came on the scene about 3 years ago, and it's been every day of our lives just thinking about sickle cell and how we can improve it. So thank you so much. At this point, we are going to bring in, I'm not sure whether Esperance is here, but we like telling stories, and I feel passionate about the people that are actually living with sickle cell disease. Everything I do, I come from my caregiver's point of view, but I've never walked in those shoes. And so today we've got Shane and Caroline. Shane is from Gold Coast. Caroline is from Western Australia. We were supposed to have somebody from Queensland. I think she hasn't managed to come. They'll just tell the story of how it is to live with sickle cell disease and the challenges and everything that they go through. So I welcome to the floor Shane and Caroline. So Shane and Caroline, we pretty much just want to hear from you. How has it been? I'll start with you, Shane. Growing up, you know, we always tell stories. I always remember the time that I was told that my child had sickle cell disease. But when you are growing up, can you let us know just how we knew how your parents told you and where you are today in terms of your experiences? Shane, please. Thank you.
Thanks, Agnes. Good evening, everyone. Thank you for this opportunity. This sickle cell, you know, as we know, it's a condition that when you're born with it actually fundamentally shapes your entire life. However, in my personal case, I don't let it define me. I've never let it define me. However, it has, and it continues to be a central part of my life. I was about 4.5 years old when I was first actually diagnosed. It was after many crises prior to that. my parents had no idea that they were both carriers. So they migrated from Fiji, came to Australia, and I was born and raised down in Melbourne, where Claire and Zane are from. Zane's actually looked after me and managed many of my crises. So it's nice to see you, Zane, tonight. And Claire actually she was my first apheresis nurse at Royal Melbourne. So it's lovely to see you too, Claire. You know, the word challenging might pop up here and there quite a bit, but I think it's a bit of an understatement, because sickle cell is one of those diseases where you can't see the actual impact it has on the person going through it, because elements of it are not visible. I've been told many times in my life that, oh, you don't look like you've got a chronic illness, but the fact remains, it is a chronic illness. It is something that is a huge part of my life. I was about 5 or 6 years old when I had a cardiac arrest with one of my crises, and was revived and resuscitated. Went back to school about 10 days later. I was 7 years old when I had my spleen removed and gallbladder as well in the same surgery. Regular transfusion started not long after that. And I grew up literally between school and the Royal Children's Hospital in Melbourne. And that was life. That was life, like bouncing between normalcy, or a form of normalcy, and then everything else. So growing up as a child was literally between healthcare management, finding out what this disease is, educating myself to the best of my ability, knowing everything I could about it, because at that time in the early 80s in Melbourne, there wasn't much awareness of sickle cell. It wasn't as well known as it is today. And I dare say even today, it isn't actually quite well known, but it is a lot better than what it was 35, 40 odd years ago. So my treatment and my healthcare management moved from Royal Children's to Monash Medical Centre in Clayton. And that actually happened because my mum got breast cancer in 1992. So it was easier for my family if my healthcare was also managed at Monash in Clayton. So from the time I was about 12 years old up till a few years ago, my healthcare was primarily managed at Monash Medical Centre. Fast forward to 2003, and that's where I met Claire, where I started red cell exchange transfusions. And this treatment revolutionized everything for me, because as you know, on the treatment side of things with sickle cell, there's crisis management, pain management, ongoing treatment in the form of blood transfusions. However, with that, you have iron overload. And in that case, that happened to me. So I had another form of treatment, which is red cell exchange. And I've been having this for the past almost 20 years. I'm currently based in Gold Coast in Queensland, and I moved up a few years ago because life in Melbourne, as you know, Melbourne is a beautiful place. I was born there. I love it. I miss it terribly. But the climate down there has an impact on one's health, especially not just people with chronic illnesses, but generally, like the sudden changes in temperature has an effect. And I've grown up with that. So I made a decision a few years ago to move up north pre-pandemic and change my life because I wanted a better quality of life. And I'm very grateful that I'm actually currently being managed at Gold Coast University Hospital, where I still continue to have red cell exchange transfusions. I just had my last one yesterday. So, you know, it takes a few days to recover from that, and then rest, recover, go back to work, the usual. It is not an easy journey, but I think it does make one resilient. And as I mentioned, to truly educate yourself on the ins and outs of it, because self-management is as important as the management that we receive as patients from our healthcare professionals, from my specialist, my GP, all throughout life. I've had amazing healthcare from all my healthcare professionals, wherever I've been. So I'm very grateful for that. But I'm actually pretty excited, and I'm really glad that ASCA and this platform and whatnot is available for people with sickle cell, because then there should be more awareness. You know, it is challenging when you're having a crisis, you're in an emergency, and your treating medical physician isn't quite aware of sickle cell, or they have never treated someone with sickle cell before, or never seen anyone going through a crisis until that moment. So, you know, being a patient and then having had to inform them what's actually going on, what this is like. So that's been a massive part of my growing up. And I think that's why early on as a child, I decided to educate myself about this illness as much as possible, just so that I could get the best possible healthcare in that time when I've been in emergency. And to end on a positive note, last year, 2020, was the start of the pandemic. Last year was the first year in my entire life where I had 0 crises. And that's basically the aim that I'm having moving forward. But yeah, in the middle of a pandemic, when, you know, things are just gone helter-skelter and crazy everywhere, and it kind of still is, yeah, I just cranked up the dial and said, I think I'm just going to manage this even more. I live by myself. I work part-time at a school in IT, and I love it. But it involves a lot of self-management, self-care, a lot of rest, and a lot of this. Yes. So
thank you, Shane.
Thank you.
I will come back to you just a minute. I just want to also give the platform to Caroline. Caroline, similarly, what sort of how's been life, you know, growing up and where you are today, and just sharing your story. Thanks, Caroline. Thank you so much, Shane.
Thanks, Agnes, and thanks everyone for joining. Yeah, for me, it was definitely quite a journey as well, and it still is, like Shane has mentioned. For me, I was diagnosed when I was 3 years old, and that was back in Malawi, where I was born and raised. With my history, it was pretty much, I was born in a family of 3 siblings, I being the middle child, and both of them are perfectly fine. So I was a lucky one and very fortunate to be blessed with this genetic disease. At first, neither of my parents knew what it was until when a doctor who was an American doctor working in Malawi, I think she was one of the missionaries, discovered that she needed to do a few more tests, because what was happening with my case, I was just one day okay, and then the next day I'm crying in pain, and people thought it was tantrums, just a child throwing tantrums, and they didn't really understand the basis of why I was constantly crying, and constant swelling up, hands swelling up, feet swelling up, and always out of energy. Well, all of my friends were running up and down, being able to play games and all that kind of stuff, but I was the opposite of that. So people didn't know what was going on until this doctor decided to do a few more tests, and then discovered that I had the sickle cell disease. And when the story was passed on to mom and dad, luckily mom was studying nursing and she was still a nurse at the time. So she understood what was going on, and then tried to get on a different diet, different way of managing my case. And yeah, it was sort of finding out what I should and shouldn't do. But as a child, it's always hard when you're being told not to do something by mom. You just think they're being difficult, so you want to do the opposite. And if they say don't go running around or don't go playing in the dust or do that, and you still do that, and then the consequences were always experienced at night, 2 a.m. I'm waking up in pain, crisis, end up in ER. So it did affect the lifespan in a sense that I was missing most of my days in school because I was spending most of my days in hospital. And every so often it was either waking up in the middle of the night, having to wake up my parents, rush to hospital, get pain management. At the time, there wasn't that many options available or many processes of managing the sickle cell other than just managing the pain. So yeah, the diagnosis came in as a relief, I suppose, because then my parents knew how to manage it and understood that I was different from everybody else. So it was more of figuring out what the next process is. So things like infections and playing around with people who might have an infection and then passing it on to me quite easily. It was just things that I needed to watch out and things that I needed to manage. So at a very young age, it was difficult to understand it. But growing up, I think after experiencing it more and reading more about it, then it was sort of like understanding what I am and what it does and how everybody else is dealing with it.
Thank you. Thank you so much, Caroline. So in terms of treatment, just quickly, because we're being mindful of time, I'll just give you maybe a minute each. In terms of treatment options, Caroline, what sort of treatment options have you had here in Australia or from, I know when you moved to Australia, things changed a little bit. So what sort of treatment options have you had?
Oh, definitely, yes. Because when I was diagnosed, there wasn't much treatment. But when I moved to Australia, I was literally 20 years old. And at the time, there wasn't a lot of sickle cell patients in Australia. I had moved all the way to Geraldton. So I don't know if you know WA, Geraldton is a small country town, not that many hospitals or not many doctors or specialists. So it was difficult for them to manage it at the time. And I was on a hydroxyurea, and they did suggest that I see specialists. But the problem is they didn't have specialists in Geraldton. So that meant I had to drive all the way from Geraldton to Perth, which is about 5 to 6 hours trip. And it was done on regular basis of 3 months. So every 3 months I'd come into Perth, see a specialist at Fremantle Hospital, check the blood levels, get onto hydroxyurea, change the dosage. If there was any need for blood transfusion, they'll make the decision then. And that meant I'll have to spend another day in Perth and before I drive back. And then we made the decision to move to Perth. So I decided to officially move to Perth, where the specialists and medical doctors were available. So right now, the medical option that I have is just the hydroxyurea, which is just a dosage to control the blood cells and make sure that the blood count for the fetal blood cells is higher than normal when you're in a sickle cell crisis. There have been a few occasions, well, not just a few, every so often with the weather change, I do get into a crisis. And when I'm in a very bad crisis, it depends on how low my hemoglobin is. If it's below 80, they definitely tend to give me blood transfusion. But if it's within the 80 to 88 mark, they consider that very normal for me. But still, it's where the energy is really low, oxygen is really low. And if it's just below that, then I have to get blood transfusion, oxygen, and just any fluid infusions.
Okay. Thank you so much, Caroline and Chen. And 30 seconds each, a message to the blood donors, because this event, we're also thanking the blood donors. It's Blood Donor Week next week. We don't want to have an event every other so often. What message do you have for the people who are donating blood in the times when you have blood transfusions?
Oh, I would definitely encourage anyone who is a blood donor to give as much blood as they can. And they may not understand how important or how crucial it is for someone, especially like me, sitting on the other end in need of blood. So it's a message to encourage anyone who can give blood to give as much blood as they can. Because in situations like this, it doesn't help if you're in need of blood and the hospital doesn't have enough blood supply. So it's always good to have that knowledge that somebody is doing something to help out. You may not know who you're helping out, but yeah, for people like me who live on blood donation from people who can give blood, I would encourage them to say, you are saving lives and those lives are really thankful. I am very thankful.
Yes, definitely, definitely. Caroline, thank you so much. We know, we've been told by the blood services that every donation saves 3 lives. So it's not just sickle cell patients and every other people needing blood in the hospitals.
Exactly.
Shane, you are on regular red cell exchange. Do you think about, who would have donated this blood for me, and what message would you have if you saw them face to face?
Just gratitude, extreme gratitude. My colleagues in my workplace have started donating blood after they found out that I have this condition. So it's wonderful. I've actually had an opportunity to meet some donors as well years back, and it's humbling as well because of these amazing people, I'm alive, and people with sickle cell and other chronic blood conditions are alive. We're able to have some kind of a normal life and give back to society. So apart from saying thank you and being immensely grateful to it, that's all I can say, really.
Yeah. Well, thank you. Thank you. I know my daughter, for the 10 years that she had sickle cell disease, we were on different options and red cell exchange. During the transplant, she had plasma, she had blood transfusion. So I know where you are coming from, again, as a caregiver. Thank you so much for sharing your stories, Caroline and Shane. I hope some of us on this platform have learned one thing or two. And at this point, I'm going to hand over to Dr. Anthea Greenway, who's going to do a presentation just to make us understand what Shane and Caroline were talking about. Dr. Greenway is the 7th member of the Nsofa family. We've known her since we moved to Melbourne. So I'll give the floor to Dr. Greenway, who is going to introduce herself as well. Dr. Greenway, thank you so much.
Can you see my slides?
Yes, please.
Yeah, okay. I'm actually going to just zip through them because it's been so beautifully described by Shane and Caroline. So I work at the Children's Hospital and Monash Medical Centre, and was lucky enough to work in one of the US sickle cell centres a number of years ago. And it will not be lost on this audience that sickle cell is a severe multi-system disease caused by a single gene change. And we have lots of both acute and chronic complications that remain a focus and cause significant ill health for our patients. But in terms of the caregivers, monitoring for these is really important. We have a vastly improved knowledge of the cause of sickle cell crises, and that relates to not just looking at that little tiny red blood cell in the middle, which is actually the sickled red blood cell, but all the other interactions of white blood cells, plasma proteins, and a whole lot of other things in our circulation that really mediate sickle cell crisis that we've heard so nicely. The sort of symptoms that, the terrible pain and symptoms that causes for our patients. And this improved knowledge has really been important in terms of drug development and many of the therapies that are coming through for patients with sickle cell disease. This slide is just to remind me, as the paediatric representative, or one of the paediatric representatives tonight, that we have, it's quite a different disease in children versus adults. And I think practitioners, as we heard from our patients, practitioners' knowledge of what they're looking for and what to look out for in sickle cell is, I think, really important in terms of making sure we get the best care for our patients. There is lots of very good evidence-based guidelines in terms of guiding our practice, and this information is really important for the clinicians in places like Australia, where we may have a lower patient number, but we are completely invested in giving great care to our patients. And this goes not only across many of the drug therapies you've heard of, but also the transfusion medicine that we're going to hear about a bit later from Kathy Cole, but also, as we've heard, apheresis and transfusion therapy. And so evidence around the best care and the best way to transfuse in sickle cell is really important. So when I think of management, it's multifaceted. It's really important to be looking out for those complications of sickle cell disease, which are likely to cause problems as the patient is older. We've heard nicely about hydroxyurea, which is our main therapy in Australia at the moment, and the importance, as Shane so beautifully said, in terms of self-management. So many of the things I'm sure he does each day are on that list there. But the holistic care of the patient in terms of thinking about how we support them to get the best out of school and career. I've just written their sickle cell guidelines, and so I think applying that evidence that we have in an Australian context is always a challenge for the medical system that's often different to some of the countries where the guidelines come from. I'm going to spend a minute in a second thinking about our Australian hemoglobinopathy registry, and we know that data is sort of key to drive change in many aspects of our lives, but particularly for medicine and getting adequate resources to look after patients. Things like the registry are really important. So Agnes asked me just to touch on children with sickle cell disease in Victoria, and just to give you a bit of an idea, we have 60 patients that I look after at the children's, equal boys and girls and different age ranges, as you can see there. And probably almost more than two-thirds of my patients are taking hydroxyurea as their main therapy. But I also look after a couple of children in the Northern Territory and a couple in Tasmania. And I think many of those experiences we heard from Carolyn in terms of being geographically isolated from your treatment centre, it's really important to think about that. We have more than 40 patients at Monash as well, of which slightly less than half are children. So the barriers, we've heard some of the barriers. I don't really want to focus on barriers tonight. I think tonight's about being really positive, but geography is a significant barrier. Australia is a massive country, and making sure that people know what they need to know to look after patients well is really challenging, I think, and one of the things that we need to sort of focus on moving forward. And I think advocacy and as the clinicians involved, making sure we're training the next generation, because we know from much of the data that some of the data we've heard about and a bit more you'll hear about tonight, that this problem is increasing. And so making sure we've got people who know how to look after sickle cell disease is really, really important. So some of the challenges in addition relate to the fact that we have a very genetically diverse population in Australia. We come from all walks of life, and that tends to modify a little bit the type of, or some of the problems that we see in sickle cell rather than some of the populations that are seen overseas. But again, this comes back to, as I mentioned before, the importance of really good data, and having information and data about where patients are from and what sort of sickle cell disease they may have is really important. So that's leading into my plug for the Australian Hemoglobinopathy Registry, and I'll thank very much Erica Wood, Neil Waters and Helen Haysom, who's on the call tonight. And I'm sure many of the audience will know about the Australian Hemoglobinopathy Registry, which is based at the Transfusion Research Unit at Monash Medical Centre. So the registry is a really important tool, I think, for us in terms of moving this forward, and it's the governance relates to having a national steering committee, but also those hospital investigators, many of whom are clinicians that will deliver care for this group. And it's really a collaborative effort between patients, families, carers, and the clinicians looking after everyone in terms of understanding sickle cell disease, thalassemia, and some of the other conditions that we see. So just for those who don't know how it works, it's a data collection tool that really allows us to think about both the management complications and some of the significant medical issues we see in sickle cell disease. And we're up to 707 as of this week. So thank you, Helen, for this very accurate recent data. 772 participants in the registry, of which nearly 350 have sickle cell. And we've got centres or recruiting sites in most states, except, in fact, I've just noticed the Northern Territory and Tasmania. So they're the ones to work on. And we're trying with this project to think about the epidemiology, how patients are managed and outcomes. The initial data drive is being funded via Novartis, and the idea is to have the data that will really inform how we move forward with improving care for patients with sickle cell. There's a number of abstracts out of this project that we presented at major medical meetings, both Australia and internationally this year. So that's a really exciting outcome for this project. So in terms of what everyone can do to help, I think ideally we'd love you to say yes when you're asked to be involved, to also talk to your carers about whether they are part of the registry, and if not, encourage them to sign up, and then encourage others that you know to sign up as well. And certainly the team are very keen to thank all our patients and families, as well as the various groups involved in the registry. So just to finish off, I think the thing I'd like to leave you with, the sort of positive frame that I think the future is incredibly positive. There's lots of new therapies moving through because of all the information we have about some of the pathophysiology of sickle cell. And so we know it's well beyond the red cell, and many of the new medications, drugs and therapies are focused on some of the other aspects of this severe disorder. We know there are many groups around the world working on cure, and that can relate to things like transplant. So this is a group called STAR, which is a transplant advocacy alliance in terms of research for different types of bone marrow transplant that may be appropriate for patients with sickle cell. And I'm sure many of the audience will have heard of some of the advances in gene therapy, which is really probably in their infancy, and there's some minor setbacks in this field at the moment, but certainly I think this condition is one of the conditions that will remain a strong focus in the gene therapy field. So this is the Australian Sickle Cell Working Group, and we had our first meeting in November just before COVID hit, so some will recognise many of the clinicians in that slide, and I'm really positive that as hopefully we are emerging from the fog of COVID. She says sitting in Melbourne in her scrubs. But anyway, as we emerge from the fog of COVID, this is a group of dedicated individuals who are really keen to provide the best care that we can for our patients. And that slide's just to remind me to say that I know we feel very isolated at the moment. The rest of the world feels a long way away and like we're never going to get back there. But these clinicians, your clinicians in this group, you know, we're all reaching out and still actively engaged in some of the global collaborative efforts to improve care for patients with sickle cell. And so I remain very positive that those relationships will go forward and help us improve care for all of our patients. And I will stop there.
Thank you so much, Dr. Greenway. Oh, you managed to. I'll just remove the spotlight. Thank you so much, Dr. Greenway, for that informative presentation. And again, I'm sure we've learned something. We are cruising through because of time. At this point, I'm going to call on Professor Catherine Cole. Professor Catherine Cole is the physician who diagnosed my daughter about 12 years ago. And she has a special place in our hearts because I did tell her that it's not true. She doesn't have sickle cell. I was a very difficult patient. But so she now works with the blood services, and she's here to give us a presentation just to understand what Caroline and Shane and how sickle cell comes in. Thank you so much again, Professor Cole. Lovely to see you again today.
It's lovely to see you, Agnes, and thank you very much. And I am going to talk from the point of view of the blood service, but I can't help myself at this stage in my career when I'm on the way out to just make a few points that I've bored people senseless with. And that is that in my paediatric haematology career in Perth, I looked after about 50 children with sickle cell disease, which was a lot considering there were none when I trained as a haematology registrar in Perth. And that just shows you how migration and refugee changes what immigration changes have occurred. And then in the last couple of years, I was lucky enough to work in the Middle East in a fabulous new hospital in Doha, in Qatar, and I had about 100 patients with sickle cell disease. And in both of these positions, I did one thing. I taught all the children and their parents that there were 5 rules of sickle cell disease. The first rule is take your hydroxyurea. The second rule is drink lots of water. The third rule is take your hydroxyurea. The fourth rule is take your hydroxyurea. And you know what? Even kids as young as 3 knew what the 5th rule was. So even though I'm as excited as everyone else about new drugs and gene therapy, I can tell you that if you push hydroxyurea in your patients from as early as possible, so 6 months of age, they don't need transfusions. They do not have sickle cell crises. And I know that they will grow up to be healthy adults. And the reason I did this with such fervour was because having never seen a patient with sickle cell disease, I wrote to some colleagues in London and said, can I come and work, for a week or 2 in your unit and find out about this disease for my patients back home? But I only had a set period of time that I could be there. And of course, my London colleague, the paediatrician, was on holidays. And he said, well, why don't you work with my adult colleagues? And I now recommend to all my paediatric haematology trainees that you must go and work in adult haematology, because you have to know what it is you're preventing, particularly in sickle cell disease. So that was where I saw what a horrid disease this can be. People with renal failure on oxygen at night, how difficult pregnancy was, how, you know, they all needed hip replacements. Very few of them could work. It was terrible. And that drove me to be absolutely rabid about doing the one thing I could do, which was make sure everyone took their hydroxyurea. So anyway, end of that, because I'm no longer a paediatric haematologist. I'm an employee of Lifeblood. And so I've just got a few slides here just to tell you what we're trying to do from our end of things to help for when patients do need transfusions. And despite my best efforts with hydroxyurea, we definitely do need transfusions in sickle cell disease. So as this audience well knows, blood grouping is much more complicated than just whether we're A or B or O, and what our rhesus D status is. And there are now at least 41 different blood group systems that we know about, and over 350 different blood group antigens that we can type for in one way or another. And these are very much spread according to our ethnicity. And even though the demand for red cells in Australia has gone down in the last few years, and that's been because of good practice in the way we practice all sorts of branches of medicine that use transfusion, the number of orders we've had at Lifeblood for phenotyping, so matching it more than just A, B and rhesus D, is going up and up. And that's a good thing. So why would we want to phenotype match blood? There are two main reasons. I'm going to come to the bottom one first, because this is where our patients with sickle cell disease fit, and it's to avoid having an antibody, which makes cross-match so difficult. So if someone already has an antibody, then we want to avoid them forming any more. Patients who need chronic transfusion support, like some patients with sickle cell disease, and of course babies requiring intrauterine transfusion. And then there's another group of patients, and it's those who might already have an antibody or where cross-matching is particularly difficult, like autoimmune hemolysis. So if you see a bag of blood now, and many of you who are having transfusions will look at the bags of blood that are being hung when you have them, and you'll see that there's now an extended phenotype on the bag, so that we're trying to match blood much more to our patients so that we don't see problems with antibodies. And now, if we move from phenotyping, one method of testing in the lab, to much more complex genotyping, then we can look at all these very complex and rare antigens. And we're aiming at Lifeblood to genotype at least 1% of our donors every week. And we're particularly aiming at people who've been born overseas or who are happy to say what their ethnic background is. So we've added to our donor questionnaire some questions which are entirely voluntary about ethnic background. And if people are keen to give this information to us, then we can more closely match our patients who also come from different ethnic backgrounds with blood that's more likely to be matched. And we've got, this slide says 8,000 donors, but it's now up near 10,000 donors where we've fully typed them. So that's all I wanted to say today, but we're working very hard to support our transfusion community with blood that matches as close as possible. And we ought to be able to do this in a country that's as ethnically diverse as Australia. So thank you, and thank you, Agnes, for inviting me yet again.
Thank you, Professor Ko. Natalie, please.
Thanks, Agnes. Hi, everyone, and good evening. Just as a quick introduction. So my name is Natalie Kapuya. I am also one of the co-founders of ASCA, along with Agnes and Preston. I currently operate as the board secretary, and I'm also on the executive. So as you can see, Agnes is always the passion, and I'm always at the back, you know, one of the architects to make sure that we get our strategy going and we do make some changes. So how I became involved in this is that I am a caregiver. I can recognize a few familiar faces, particularly Dr. Greenway, who is also a member of our family, as we call it. So without going too much into that, I just have a few questions for Anthea and Zane, and maybe I will just start with Dr. Zane. I know we have met in the past at Monash before I moved. So Anthea spoke about some of the challenges in terms of managing and treating SCD in Australia. And obviously that's mostly from the pediatric point of view. What are some of the sort of challenges that you see on your end, Zane? Thank you.
So I think Shane outlined one of the major challenges that we have is that in Melbourne, we've got 2 adult sickle cell centres that are really expert in managing patients. There's Royal Melbourne that's overseen by Kylie. And then at Monash, there's me and I work together with Anthea and another haematologist, Charlotte Vilcassam. I think one of the major challenges we've got is the lack of knowledge in peripheral hospitals and other centres around Australia or in Melbourne where other patients do present, and trying to make sure that we can reach out to those centres and ensure that when patients do present there, they're appropriately and adequately managed. The other challenge that we have is not all of our patients live in capital cities. And so, for example, we've got a patient who lives on the border in Albury, which was quite of a challenge with COVID, trying to transport someone across the New South Wales border into Victoria for red cell exchange. We actually got lucky and Canberra helped us out when New South Wales ambulance refused to drive over the border into Victoria. So I think geography is a big challenge for us, and also the lack of expertise outside of a very small number of centres.
Okay. So in terms of expertise and to make sure that it's basically consistent across the board, you know, especially in these peripheral areas, what are some of the initiatives that you, that you have looked at, to try to bring them across and, to be the same as Melbourne, for example?
I don't think we'll ever make them the same as Melbourne, but we've got partnerships with physicians in certain centres. I know Anthea works with some paediatricians, say, for example, in Bendigo, where we co-manage patients. And so they'll have their care locally, and those clinicians will then liaise with us on managing the patients. But I don't think you'll ever be in a scenario where you have expertise in a small centre where there's 1 or maybe 2 patients. So I think really it's about forging partnerships that enables you to manage those patients adequately.
Okay. And maybe for Anthea, one question around challenges, especially from the patient point of view, and Zane can also answer that a bit later, is that one thing that we've heard a lot from patients or from caregivers is that in the pediatric setting, people feel so nurtured that if they could live there, live there for the entire lives being taken care of, it's that there is quite a stark change to when they transition to adult care. So how are you trying to bridge that gap? And obviously later on, I want Zane to answer how he's also working across with you guys to make sure that people don't desire to stay in pediatric for their whole lives, but actually move on and still get the same level of cares and attention.
Thanks, Natalie. I think that is a challenge. I think there are some inherent differences in the way we manage children and adults, and I'm sure many of my adult colleagues are often a bit cross with me when they get the patient because of some of the expectations. Some of the expectations we have in paediatrics don't really fit with being an adult and making adult choices and adult decisions, I think is one way to look at that. I think we have vastly improved, like all things to do with sickle cell, this is in evolution in Australia. And as Kathy has said, and many of the clinicians will say, it's growing in from similar to Kathy. I maybe had a few patients when I was the trainee, and now I have the numbers you've seen. I think it's about the next generation and investing in positions. So there's been a hemoglobinopathy fellowship in New South Wales, and we've got a fellow position here at an apheresis position here at the Children's. It's about teaching that sort of next generation. It's about looking after patients very well in paediatrics, as Kathy has mentioned, with amazing treatments such as hydroxyurea, so that when they get to adult practitioners, they're in great condition, and really we're just continuing to maximise their health and keep them incredibly well. I think as clinicians, we all acknowledge how difficult it is to take a medication every single day. If we think about how hard it is to finish a 14-day course of antibiotics, being on something every day is really hard. But, it's such an amazing opportunity to keep patients well. So I think coming back to your original question, there will always be differences, I think, in the way we manage paediatrics and adults, and transition planning and communication between the centres and collegiality, which all of which is, an investment that we're all prepared to make, I think is important to help patients move seamlessly from one service to the other, or in the case of centres like Monash, which is a whole of life service that really provides an opportunity for patients to not necessarily have to move or change too much as they move through.
Okay, thanks, Anthea. So Zane, same question. So probably, how do you manage those expectations? And also, how have you seen those expectations maybe lessen because things are, becoming more seamless across the board? Are you on mute, Zane? Agnes,
yeah, no, it's all good. Sorry, my mouse froze. Sorry. One thing I do take exception to is that we don't provide a nurturing environment. I think we aim to provide a very nurturing environment. One thing Anthea did touch on is that we do provide a whole of life service. So I get to know the kids very young, because when Anthea's not around, I go and see the kids when they're admitted. And also when Anthea's not around, I'll see the kids. And similarly with a lot of the adults, Anthea will be involved in their care as well. So we have a bit of a unique situation at Monash. But I don't necessarily think it's about nurturing. I think part of growing up is that everybody has to learn to stand on their own feet. And I think it's often more difficult for the parents rather than for the kids. I have a different perspective on it because I also work in the haemophilia centre at the Alfred, and I see the difficulties there in transition much more than I do with the sickle and thalassemia patients that work with at Monash, because we have that whole of life service. And I think often it's really the expectation of the parents rather than the children. And I think it's education for both parents and children, that the parents need to understand that the patient or the child is now an adult and they need to make their own decisions, and that whilst we do want to involve the parents, it's not the same role where the primary contact was the parent, and then the parent was kind of responsible for informing the child and making the decision. Now it's really the child, their child, who's now an adult, who needs to make the decision and inform the parents of the decision that's being made. And I think it's a change in the dynamic of that relationship between the parents and the child that is one of the more difficult things to bridge.
Okay, thank you. And another question that I also have is that, so Anthea touched a lot on the patient demographics in her patient base. Are those similar for the adult patient base? And if so, how does that impact their treatment plans?
So historically, a lot of our patients have been in the adults have been, first and second generation Australians of Mediterranean and also Middle Eastern background. Whereas over probably the last decade or so, we've seen a lot more student migration, a lot more people from Africa, and the difficulty with a refugee group or a group that has come that are not as financially well off as some of the Italian and Greek patients, relatively speaking, is a challenge for treatment. Also, language is a problem. We've had significant issue with patients not being able to afford their regular medications, not being able to afford transport to hospital. And we endeavour within the unit to help out where we can. We've got a bit of a slush fund that we use to, put money under the cupboards and hide it from the hospital and use it to pay pharmacy for medications and transport. But that is a real problem in some of the refugee communities now, where money is a big problem, both for medications and also for healthcare. Because if you're struggling to make rent and pay for food, and you have a sickle crisis, that's taking time off work, not working. And so patients' healthcare gets neglected because the priority is really staying in work, earning money, rather than looking after their healthcare. And I think that is a big challenge for us with the refugee communities, as opposed to some of the groups that historically we've looked after in Australia.
Thanks for that. And Anthea, same question. I mean, in terms of the patient demographics, how have you seen that impacting the treatment plans and options that you have available?
I think one of the implications for patients from different parts of the world is inherent one of the barriers to hydroxyurea, I find, may be related to some misinformation about the medication. And sometimes that's come from sources that may not be medical, but are strongly based on where a patient may come from. So some patients say to me that the people back home don't believe in that medication and are not keen for the child to take it. And that can be a real challenge for me to deal with, when similarly, as Kathy's mentioned, taking hydroxyurea can be absolutely life-changing for many patients. Sometimes some of that misinformation is very hard to challenge and very hard to move, and takes a long time to sort of get through. So I think that's one of the issues in terms of where patients may come from, and their sort of history and background may influence their care. I think the thing to say is that we have a large variation in our population, similar to many of the diseases that we look after. And I think it's the message that sickle cell disease affects people from all walks of life. Certain groups of patients are more represented than others, but I think there's some commonality to that allows us to sort of move forward and try and look after the patient. I think, as I mentioned in my talk, we have a fairly diverse population. Many of the populations managed overseas are very similar in terms of the presentation and the gene, and sort of how that presents. And so that often, I think, affects the sort of cohorts and the clinicians and the patients looking after them, whereas we have much greater diversity. So I think it's important to keep that in mind. And I think it does affect presentation and complications that we may see.
Okay. I'm actually also a bit curious about that cultural aspect. So how do you try to navigate that, knowing that, obviously it is quite important that the people affected do get the best quality care, and you do have that available, even by offering an option such as hydroxyurea, for example. How do you help them get over that line? I know it might be a bit of a difficult question to answer. But
yeah. Oh, look, I think I'm a firm believer. I introduce the topic very early, usually at the first meeting, if not the second meeting. I am prepared to be really patient, and I'm prepared for people to ask me lots of questions and go away and do their own research. We have very good literature from many centres around the world to provide, and good quality literature. So I always say to families, I know you're going to go away and Google. I want you to do that. I want you to write it down and come back and talk to me about it. Some sources will be really good. Some sources will be less good. So I think information is key to challenging misinformation. but patience and working with the families to answer their questions and really sort of showing them and giving them practical examples of how it might help their child is really important.
Okay. Thanks, Anthea. And my possibly last question, I'll try. So in terms of the trend in ED presentations, how have you seen the needle shift, over the years, for ACD patients? And then maybe another factor is, especially when you have different patient demographics, how does that present?
Do you want to go for it, Anthea?
How have I seen things change in my last few years?
In terms of the ED presentations, for...
In terms of ED specifically?
Yeah, in terms of ED specifically.
That's a good question. I think we have spent time trying to educate, as I said, other medical practitioners and raising the profile of sickle cell in centres that we're all involved in caring for. So I think that has helped in terms of getting better access to care for patients coming through emergency departments. I think as the patient numbers have improved, that has really meant that we have people who have some more experience. It may not be a high level of experience, but they've at least seen things before. And I think the building relationships, as Zane mentioned, with other carers in other settings is really important, so that people are prepared to pick up the phone when they have a patient where it might be a consideration, so that the treatment is started earlier. So I think development of guidelines, which has happened in many of the centres in Australia, has also helped. So most paediatric centres and adult centres like Monash would have a guideline that people can go straight to in terms of who they call when this happens and how they're going to sort of start treatment for the families. I think strong roles in advocacy for things like use of interpreters and others who may help in settings like emergency, which can be pretty confronting for people who are not who are from a different country and find themselves in a new situation. That can be very challenging. I think that's really challenging for our refugee families, trying to navigate healthcare in that setting where they don't speak the language and the system is very different to what they're used to at home. That's challenging. I think that's an ongoing thing that we will need to keep working on very hard to help for many of those sorts of situations. Did that answer the question?
Yes, thank you. And Zane, same question. Do you want to?
So to be honest, I haven't seen a great difference in presentations to our emergency department. We've got reasonable protocols in place. All patients have a letter that they're a known sickle cell patient of the hospital. So to be honest, I haven't seen, there hasn't really been a great deal of change that I can see within the emergency department presentation. One thing that we have had on occasion is, again, with the student population, patients who are not known to our unit, but are known sickle cell patients who've presented to emergency departments and not known to a centre. And that does create a management challenge when you've got no record on the patient. You don't really know what their disease history is. And that is a challenge, and I think we're going to see that more and more.
Okay, thanks, Zane. And now I have a question from Facebook from one of our audience members, David Owoye. I'll try if I pronounce that right. So his question is, so I have a question about antibiotics and preventative management. When this recommendation was developed, we had little information about antimicrobial resistance. Now, with more light shed on, I think he probably says he would like more light shed on antimicrobial resistance. What should be the evidence-based recommendation for the use of prophylactic antibiotics in sickle cell disorder, considering this type of resistance? Anthea?
I would pretty strongly say I don't think we have good evidence that there is a high rate of antimicrobial resistance from once-a-day prophylactic amoxicillin, which is the usual regime we use in children, particularly with sickle cell, prior to them being completely vaccinated. And I think the risk of overwhelming sepsis and severe infection far outweighs any issues. So individually, I'm not convinced that there is a high risk of antimicrobial resistance with the strategies that we currently employ, which go beyond actually just sickle cell. It's actually a strategy we use in many haematology patients where their spleen doesn't work.
Thanks, Anthea. And to Zane?
Well, I agree with everything Anthea said. Kathy Cole will probably disagree with what I say with this, but I think the biggest change or the biggest life-saving thing that we've done for people with sickle cell is routine antibiotics. And I think that really is what has made almost the biggest difference, and not downplaying Hydrea, which I think is a fantastic addition as well and advocated for all of my patients. But really antibiotic prophylaxis, it really does save lives in sickle cell. When you have a look at the average life expectancy of a child with sickle cell in the 70s compared to, you know, what happened with the introduction of antibiotic therapies later on in the 80s as the first trials, a long time before I started doing this. And with regards to antibiotic resistance, I think we're using penicillin or amoxicillin, and we're targeting a very specific type of bug, the ones that are, the spleen is important for providing immunity or providing protection against, which is deficient in patients with sickle cell. We're not using broad spectrum antibiotics that lead to widespread antibiotic resistance. So I think we're dealing with a very different scenario here, and I advocated for all of my patients.
Okay.
I agree entirely, Zane.
I was going
take
to
that
add
for
that.
granted. Yeah, they're all on penicillin or whatever by 6 weeks, and hydroxyurea at 6 months. That's my mantra.
Yep.
Okay. Thanks, Anthea and Zane. So Agnes, over to you so we can proceed with our program.
Yes, thank you so much, Dr. Greenman and Dr. Kaplan. I've only got 2 last questions. So one of them is about hydroxyurea. Do you have any percentage of people living with sickle cell disease who are resistant and you don't have any other options, or what options do you have for them if they're resistant to hydroxyurea?
Does anyone want me to go first?
Yes, yes.
I have to say that there is variable evidence in terms of whether hydroxyurea actually exists, and you know, I think it's a hard thing to prove or disprove. I think that often our challenge is compliance rather than resistance. And you know, but there is variation to how well or not well people will respond, so that certainly is true. In terms of, I think there will be a group of patients who do need intensified treatment, and currently that would be, as we've heard from Shane, you know, things like apheresis and red cell exchange as our preferred transfusion strategy often offers significant relief to patients where hydroxyurea doesn't work, and certainly the combination is also a possibility as well.
So on hydroxyurea resistance, it depends what you're defining as resistance. Some people will see a failure in the rise of the hemoglobin F as a marker of hydrea failure. But as Anthea showed in her slide, the really complicated one of the immune response that's mediated by sickle cell, I think hydrea does a lot more than raise the hemoglobin F. It has a significant effect on white cells, probably the endothelium as well. And so I think just merely looking at the hemoglobin F may downplay the efficacy of hydrea. And so I don't think that should be a marker of hydrea resistance or hydrea failure. For the patients that continue to have significant events despite maximally tolerated hydrea, currently really our only options are transfusional therapies and those with more significant events to consider transplantation.
We have a duck fill that has been approved by the TGA, which I know can take up to 12 months. Do you feel you start introducing that treatment options once it's available?
I don't really know what its role will be. And when you look at the trials, it's additive to hydrea. It's not a cure. I don't know what the place will be in the future when we have access to the selectin inhibitors relative to hydrea, and where that will fit in with transfusion support in Australia. I think one thing where we are fortunate in Australia, and that's thanks to the hard work of Lifeblood, is that we do have a very safe blood supply, and also we're a relatively rich country where we can afford these therapies like red cell exchange. So I don't know at this stage which patients will put on a selectin inhibitor in addition to their hydrea, or which will put onto transfusion support, or which patients who are on transfusion support would be keen to come off that and try additional therapy with their hydrea. So I think we really need to wait and see, one, for it to become available, and then what our local experience is with it, to be able to really say what kind of change it makes to our therapy.
Okay. Any input, Dr. Greenway?
Oh, look, I think, you know, some of the models of care coming through involve multiple medications which target different parts of the sort of disease-causing issues that we see in sickle cell. I think that adds complexity for the patient. So, you know, I think it is an option. There may be some patients where transfusion therapy is either difficult, or there are other reasons and that they wouldn't pursue that. I think, as you've heard from Shane, many patients on chronic transfusion feel really well on this therapy. And as Shane said, the safety of blood and our ability now to manage iron overload with exchange is significant. We have, you know, that's very good experience. Claire would certainly be able to comment on this, a large number of patients who've been on exchange for a long period of time. So I think it's great to have options, but, you know, it will be a very individualised decision in terms of who ends up on that therapy. I don't think that's an easy therapy to have either. So I think the balance of the complexity of the daily regime may well be a challenge for some patients as well.
Okay, thank you so much. Just one more last question. With the COVID pandemic and the vaccines, what message you have for people living with sickle cell disease in terms of getting the vaccine, if you are specialized in that area?
I just say get vaccinated.
Not quite licensed for paediatric patients yet. Licensed above 16, will soon be licensed 12 to 15, and then the last age group will come through. But patients with sickle cell are at increased risk and certainly should access vaccination.
Okay. And just lastly, how can we better work together to partner with you know, patient organizations to better support families and people living with sickle cell disease? What message do you have for us?
Do you want to go first, Shane, or me?
Go for it.
Look, I think it's great to have this partnership and the opportunity to work together to, you know, help us to hear the voices of the patients that we look after. I think we come from unique perspectives that allows people in positions of power who are making decisions. Our job is to try and, I think, help them from both sides of the equation make the right decisions moving forward in terms of getting better care and better outcomes for our patients. So I think it's collaborative. Kathy's written there, pass on the 5 messages. We should give the bean counters those 5 messages. I agree, Kathy. But we need to work together, I think, to give the same message and to help as much as we can understand from both sides in terms of some of the complexities or challenges we face to, you know, have best care for our patients.
Thank you so much, Dr. Greenway and Dr. Kaplan. That's very, very informative for all of us on this platform. And we'll move forward. I know we're a bit of running late. And thank you so much for, I think Caroline has to leave. Thank you so much for that. At this point, we'll bring in Caroline Cameron. No, sitting in for Caroline, sorry. The genetic counselor, so we'll just give
Miranda.
Miranda. Yes, sorry. Miranda sitting in for Caroline. Thank you so much, Miranda. You can take it up. Thank you again, Dr. Greenway.
Hey everyone, can you hear me okay?
Yes, please.
Great. And can everyone see that PowerPoint?
Yes, we can.
Perfect. So everyone, my name's Miranda. I'm a genetic counsellor. I work at Monash Hospital in the genetics department, and I work alongside Dr. Anthea Greenway and Dr. Zane Kaplan pretty closely to provide genetic counselling to families impacted by sickle cell disease. So today I'm just going to talk a little bit about the genetics of sickle cell disease and the genetic counselling that I provide to people in relation to that. So for those who don't know, genetic counselling is the process of helping people understand and adapt to the medical, psychological and familial implications of genetic conditions. So what we do involves interpreting family histories to better understand the chances of genetic conditions happening again in a family. We provide education to families, so information about things like how conditions are passed on, what testing is available, and how those conditions can be managed. And finally, we integrate counselling into that process. So that's about helping families to make informed choices and adapt to finding out about a risk or a genetic condition in the family. So sickle cell disease comes under a group of genetic blood disorders called hemoglobinopathies, and that group includes the thalassemias as well. And these conditions affect hemoglobin, which you probably know transports oxygen around the body so we can get energy from the food that we eat. To understand the genetics of sickle cell disease, it helps to understand how hemoglobin works. So basically there's the iron, and then there's 2 alpha globin chains and 2 beta globin chains, and they come together to form that hemoglobin molecule. Now, hemoglobinopathies happen when a person gets changes in the genes which contain the instructions to make those globin chains. So we call these gene changes or gene mutations, might be a common word that you've heard used. So hemoglobinopathies are not rare around the world, and as everyone sort of mentioned, as Melbourne becomes even more multicultural, where we're seeing a lot more of sickle cell disease, particularly. In some areas of the world, up to 1 in 4 people are carriers of sickle cell disease. And it's thought that people who are carriers actually have some protection against malaria. So it's really common to be a carrier in places in the world where malaria is common. So in sickle cell disease, a person produces hemoglobin S instead of the normal adult hemoglobin. And that hemoglobin S has an abnormal structure, which, as I'm sure you all know, leads to the red blood cells sort of distorting into that sickle shape. So during these episodes of sickling, the red blood cells can form that shape and can block the blood vessels, and can also cause the red blood cells to break down more prematurely than they otherwise would. And as Anthea's PowerPoint showed, there's a lot of, I guess, other much more complex mechanisms that lead to the symptoms that people with sickle cell disease experience. And that's just, I guess, a very simplified image of how those red blood cells can sickle because of the abnormal hemoglobin. So why is this hemoglobin S produced? So it all comes back to our genes. So as you might know, our genes contain the instructions for our bodies to grow and function. We've got about 30,000 of those genes. So there's a gene for hair color, eye color, everything in the body, and there's genes to create those hemoglobin, the hemoglobin molecules. We get a copy of all our genes from each parent. So one copy of all our genes from mum and one copy of all our genes from dad. In terms of the genetic basis of sickle cell disease, we've each got 2 of the beta globin genes, which are the ones we're thinking about when we're looking at sickle cell disease. So 1 beta globin gene from each parent. Now, there is a specific change or mutation that can occur in the beta globin gene, which leads to sickle cell disease. And that change is known as hemoglobin S or HbS. You might have heard the term being a carrier for sickle cell disease. So what it means to be a carrier is that you've got 1 normal copy of the beta globin gene and 1 copy with the HbS gene change in it. Now, carriers are usually healthy and don't usually get any symptoms of sickle cell disease because that 1 normal copy of the beta globin gene is enough to stop you from getting symptoms. People with sickle cell disease will have that HbS gene change in both copies of their beta globin gene. So they've usually got 1 from each parent. In terms of how this condition is passed on, it follows what we call autosomal recessive inheritance, which is sort of a fancy word that means both parents have to be a carrier of sickle cell disease to have a child with that condition. So I think Shane mentioned, you know, his parents were sort of found out to be carriers after he was diagnosed. And carriers don't usually have any symptoms, so there's no way to know usually. So if both parents are carriers, there's a 25% chance of having a child with sickle cell disease if they both pass on the gene change. That's the same chance for every child that you have. So it's sort of a separate risk for each pregnancy or for each child. Unfortunately, we can't sort of predict what's going to happen. So sickle cell disease can also happen if 1 parent carries the HbS gene change and another parent carries a different type of change, but still in the beta globin gene. So if 1 parent's a carrier for beta thalassemia or another variation in the beta globin gene, there's still a 25% chance of having a child with sickle cell disease or a slightly kind of different variation of that disease. In some cases, it can be milder or slightly different to kind of the standard presentation. So sort of bringing it around to what I do as a genetic counsellor. So in Melbourne, most couples will have screening for hemoglobinopathies. And the reason we do this is because there's no way to know that you're a carrier without having the testing, because you usually don't have any symptoms. Now, this carrier testing is often organised by a person's GP or a midwife when they find out they're pregnant or if they're planning a pregnancy. And if 1 person in the couple is found to be a carrier, then it's really important for the partner to be screened as well. If only 1 of them is a carrier, then it's a very low risk of having a child with sickle cell disease. But if both parents are carriers, then usually what happens is the couple would be referred to genetics, so to me, and I would arrange to see that couple to talk about the chances of their child having sickle cell disease and what that would mean. And just something else that's, I guess, to note is that there are now some tests available called reproductive carrier screening, which can look for lots and lots of genetic conditions as well as sickle cell disease. So that's an option for some couples who want to, do more extensive testing for genetic conditions. So when I see a couple who are both carriers for sickle cell disease, we talk about the options for them if they're planning a pregnancy. So there's the option to conceive naturally, and some people might choose not to have any testing at all, or to test the baby at birth is sort of, I guess, what we recommend. So if the baby does have sickle cell disease, we can start those treatments that everyone's mentioned as early as possible. And some couples want to know before the baby is born if it's going to have sickle cell disease or not. So for those couples, we can offer something called prenatal diagnosis, which is where they can have a test in the pregnancy that I'll talk about a bit more in the next slide that can tell us before the baby is born whether or not it's going to have sickle cell disease. There is an option to use IVF where embryos are created outside the body using IVF technology in a lab, and genetic testing is actually done on those embryos to see which ones are expected to have sickle cell disease or not. And the IVF service would only implant embryos that are not expected to have the condition into the mother. So that's sort of a pretty complex and expensive technology, but it is available to couples at risk. Some couples might also choose, if they don't want to pass on the HBS sickle gene change, they might choose to use a donor egg or sperm or embryo. And then some couples might choose not to have children or to adopt if they are really concerned about passing that condition on. So the only way to find out during pregnancy if your child is expected to have sickle cell disease or not is through what we call invasive testing. So a CVS or an amniocentesis, and both these tests involve a long needle going through the top of the tummy into either the placenta or the fluid around the baby. So they don't go into the baby, but they are still an invasive test and do have a small chance of miscarriage associated with those tests. The CVS can be done from around 12 to 14 weeks, and the amniocentesis is done a bit later in pregnancy. So we talk to couples about these options and sort of, what the risks and benefits might be of having that testing. In terms of the outcomes of that testing, so if people choose to have a CVS or an amniocentesis, genetic testing is then done on that sample to see if the baby is expected to have the condition or not. If the baby does have the genetic condition, so sickle cell disease in this scenario, parents do have the option to either continue or not continue and terminate that pregnancy. This is obviously a choice, a really difficult choice for each couple, and it's an extremely personal decision. There's no right or wrong answer, and our roles as a genetic counsellor is to support couples through this decision making by providing all the relevant information they need to make the right decision for them. So we try and provide unbiased information and not be judgmental at all about whichever way they choose, and support couples through that whole process. For some couples, they will be continuing their pregnancy regardless of whether the baby has sickle cell disease or not. So they might choose to wait and do the testing at birth because they don't want to risk having that invasive needle test. So yeah, that's really, I guess, a little snapshot of what I do as a genetic counsellor and just my contact details. I don't know if anyone has any questions or comments.
Thank you so much, Miranda. Because we are running out of time and powering through, we will quickly go into just 5 minutes for the caregivers. We have Natalie, Mwewa, and Dillis I'll give you maybe 2 minutes each just to talk about your experience. And Dilys, you're going to talk about your, is Dilys here?
Yes, I'm here. Yes.
Yeah, so just talking about your experience with genetic counseling and where you are today. So Natalie Mwewa, just a quick introduction and just your experience quickly. Thank you. Mwewa, you can start.
Okay, thank you. Thank you very much for this time. My name is Moa Chisenga. I am a mother of 2 daughters with sickle cell disease. Live in Adelaide. Yeah, just I guess to answer your question about my experience as a caregiver, living with children with sickle cell disease and the like. Our experience, I guess, how we got to find out is my eldest daughter was diagnosed when she was probably about 1.5 years when we were living in Botswana. And because of that, when I was expecting my second child, I mentioned to her pediatrician that my child has sickle cell, and so was sent to have tests when my second daughter was 2 months old. So that's how we got to find out. In terms of our experiences in medication and treatment and the like, it was very challenging initially. I know when I went to the Westmead Children's Hospital, the hematologist specialist we saw at the time gave us a long letter describing the girl's condition. It was very, very technical jargon, which I didn't understand at the time. So every time I presented to the emergency department when we were living in Townsville, I had to move around with that letter. I kid you not. So every time I came, I'd say, my kids have this disease, read this. You guys would understand that a little bit better than I do. So that was the saving grace. And so people would read up, do Google searches whilst we're in consultation. And that's how we got to know that. Both my girls are on blood transfusions. They've been on it since my oldest daughter had a stroke when she was 9 years old. So they've been on it, again, just to try and make sure that their sickling levels are below 30%. So they've been going through that, and that has presented its own challenges. I think when they were younger, it was very much a case of, yeah, you know, as a mother, I was in mother mode. So we just go, we got to do this. We got to do this every month. You know, go and have your blood tests 3 days before, two days before the transfusion, and then go for the transfusion on the Friday. So we have it on a Friday every 4 weeks. So it's just been our life, really. Medications, appointments, and living in regional areas. We would have to be shunted to Brisbane. The time we were in Queensland, we'd go to Brisbane for a week, have all these specialist appointments done in a week, echoes and everything else done, then go back to Townsville. So that's been our experience. And having moved to Adelaide now, we're fortunate that we go to the Michael Rice Centre at the Women's and Children's Hospital, and we have a really good team of hematologists and nursing staff that we do their very best to look after all the children that come for transfusions in that place. So that really has been our experience. But having now moving into a different space now with my oldest daughter transitioning to the Royal Adelaide, as she's considered an adult now. So it was very interesting to listen to the conversations about management of, you know, that transition. And we were very fortunate that our pediatrician, our hematologist, Dr. Powell, connected with the adults, a consultant over at the Royal Adelaide, and they did a handover, and that was a really beautiful thing. I can't stress that enough, doing a handover with us present and talking through it, so at least we can get familiar with the new specialist. And yeah, that was a really, really beautiful gesture. But I'm very aware that not everybody is able to get that kind of service, if I can call it that. Yeah, so that's really pretty much been our experience in trying to transition and move and navigate. So most days I'm in 2 places. I drop off my youngest, check her in, then drive across to the Royal Adelaide to go and check in my other daughter, then drive back to stay with my younger one. So I'm doing a bit of both, but hopefully once my older one is a bit more confident, I can then just let her go in, check herself in, have her treatment, and then just pick her up.
Thank you so much, Moima, for that information. I can relate. We moved 3 states, and yes, part of life being a a warrior mom. Dilys, quickly, just introduce yourself, your experience, and how we connected, and how are you doing? How's your son?
Okay. My name is Dilys, Dilys Chi. I'm a caregiver for a 9-month-old boy. So basically, in regards to how we got to know he's got sickle cell, it was through CVS when I was pregnant. So we decided to do a CVS. Well, you say, why did I decide to do the CVS at that point? We actually did it, the test to check if we are carriers. That's before pregnancy. Unfortunately, our GP didn't actually emphasize to us in that regards when it came that we were both carriers. He didn't point that out to us and say, look, maybe you guys should go for genetic counseling and so on. I don't know. I would say maybe I should have known, but at the time, my mind was probably not looking in that direction, but I really wish that the GP had pointed that out. Anyway, during pregnancy, we discovered that baby had sickle cell. So it was a very emotional time for me and for my husband and for family. It was really, really emotional. We got through it through friends and family, and Agnes especially supported me through that journey. I really remembered calling Agnes, and I was in tears. I never knew Agnes. I saw her name on Facebook under the ASCA advocacy group. So I did call, and she spoke to me from then, and we started speaking. And I think she was one of the big factors for me eventually deciding on being calm and controlling my emotions and looking forward to the baby. The baby, he's been doing quite okay. He's had a few crises. I think 2 crises so far, 4 months and 6 months. They were not that major because I was able to manage them at home. And in regards to the doctor, she's very, very supportive. Dr. Tio at Westmead Children's in New South Wales, she's very, very supportive. She's led me through throughout this stage. At the moment, the baby is on hydroxyurea, and I think it's working really well for him. We've been through we've gone through the first blood test to check how his bloods are doing, and they're responding really well. And at the moment, baby is doing great, I would say. And in terms of my husband and I think we've come to being able to I would say being able to be able to control our emotions and look after baby in a very different way, not thinking that baby has sickle cell. Yes, and that's very important, I would say. And yeah, baby is doing great, and I don't know what else to say. Yeah, he's doing great, and that's baby else. Nathan, say hello.
Hi, Nathan. Well, thank you so much, Dilys.
Yeah, that's fine.
I do remember the phone call. I just got a phone call, a message of somebody crying. I was like, who's this? And, I'm so glad we connected. We've done so many things together with this family. Where and Natalie, we supported you and doing the best. We had a virtual baby shower. So
that's right.
Well, quickly, Natalie, you've said your story. Just anything you can emphasize, but also, and just talk about the blood donors as well, and we finish off through as we.
Okay, I'll try to be brief. I definitely resonated with a lot of the stuff that every panelist spoke about, from Shane Okay, so in terms of genetic counseling to start off with, we had ours done after birth. It was a bit of a shock to actually find out that this particular test was done in Australia. And at the time we had just moved here. So I just thought, oh gosh, maybe this is not the right place for us, you know, especially coming from Africa, where we know that, you know, it can be pretty dire. And of course, emotionally, as I hear Dilly's, I totally understand. It's life reimagined, you know. Yes, you know, you do definitely go down the valley and it is pretty dark here. But then I also can relate to hydroxyurea. I totally agree with Dr. Catherine Cole. 5 rules, yes, hydroxyurea and hydration. I was definitely one of those who was a bit resistant, and yeah, I can definitely attest to that. I think we had many conversations where Anthea patiently tried to, you know, to advocate, I would say, for my daughter to move on to it. I think it was definitely a great decision, especially when we came to the conclusion that, you know, with SCD, it's not just about the person that is living with that condition. It affects the whole family, you know. So in that sense, you know, the quality of life is not just for that person, but it's for everyone. And I had to think, okay, do you want to be in a hospital while you have another young child to look after who might feel neglected? So you definitely have to make a better decision for this person, especially once you educate yourself as well. Very important, you know, even as a parent. And one very important thing that I do also advocate for is keep those channels of communication open with your physician, with your doctor. I think Anthea has always made us feel very welcome, you know, to voice our opinions. And as I said, you know, at one point, you know, she could have led us to the river, but fortunately she just, you know, she let us come to our own conclusions and decisions. And with hydroxyurea, my daughter is doing really well. So it means that like Caroline before, I used to be one of those who feared the cold. Shane, I totally understand Melbourne weather. But nowadays, funny enough, my daughter actually prefers the cold, you know, even, and all I do is I just make sure that we do follow the advice that is provided, and that she also understands it. You know, my goal is definitely that I do understand that one day she'll have to navigate the system on her own, and hopefully I hope that maybe she doesn't have to if there's a cure, but if that doesn't happen sooner than later, I definitely want her to be empowered. So it's always important for me to help her understand how important it is for her to take her medication regularly. Fortunately, she's so good with that many times she'll actually remind me herself, but you know, in terms of that, which is really good. And yeah, and a support network is definitely very important. Just like, you know, we created ASCA. I mean, for me, it definitely would not have been this easy if it also were not for Agnes, definitely. Yeah, I think Agnes definitely saw me through a lot of emotions, but probably one emotion at the time. Yeah. And in terms of blood donations, we've been fortunate because she's been on hydroxyurea. We have not had to have many blood transfusions. I think she probably had a couple before she went on hydroxyurea, and one when she was going through the removal of her tonsils. But otherwise, we are quite fortunate that she is responding quite well to hydroxyurea, and we make sure we are compliant with our appointments, and yeah, and just make sure that, you know, it is, while it is a big part of our lives, but it is also not the focus of our lives. I think we've gotten to the point where, you know, we still have to go on, and she still has to live a beautiful life regardless of, you know, this gift, which can be unexpected. And of course, if it also were not for blood, for people who donate their blood, yeah, people like my daughter and others here would definitely be in peril, if we can call it that, because that is when SCD is not well managed. Yes, it can be quite perilous. So we definitely encourage people out there to keep, to keep informing themselves. You never know. Sometimes, just be there as a shoulder to cry on, ear to listen to. But yeah, definitely, giving blood is very important. It does really save lives. Yeah. And Agnes, do you want me to add anything more to that?
No, thank you, Natalie. You've said it all. I'll just give Mwewa the last 30 seconds to just talk about, because you are really affected by the blood transfusions for your daughter. The message we had, we've always been talking about in terms of our life blood teams as well. If you can encourage people, donors, and just any message you have for them. Thank you.
Thank you, Agnes. Yes, I think we can't reiterate how life-saving that selfless act that all the donors do, regardless of how you put your lives on hold to go and do that. My kids are alive because of what you do. So thank you. And I just want to encourage people in our communities of color as well, just to be able to go, okay, I may not see a direct link right now, but you never know. It could be the neighbor down the street. It could be a child you have absolutely no idea. So I really just want to encourage our people in our communities to roll up their sleeves, as it were, and go to that center and go and donate blood. I think the last time we had a session, the specialists were telling us how they really want to have blood that's quite specific to in our groupings. So the more donors we have of the diverse backgrounds, the better it is for everyone. So I really just want to encourage everyone who can, please do. And for those that do, thank you very much for doing that, because as you have heard and may have seen, it's making a huge difference. So thank you.
It does make a huge difference, and I cannot emphasize that enough. Thank you so much, Natalie, Mwewa, and Dilys. I'll quickly go into Claire before we finish with Melody, and we apologize. What I've seen talking is really, powerful, and I can't stop people when they are talking, especially when telling life stories. We apologize that we're a bit late. So Claire, please, you can take over. Thank you so much. You can share screen if you need to share screen.
Can you see that?
Yes, please.
Okay. No, that's fine, Agnes. Thank you for inviting me. And it's lovely to hear everyone's stories and perspective, and just helps to reinforce, what we're doing and how we can help patients with sickle cell. So Agnes asked me to speak about, I guess, the nursing perspective. And so I'm speaking about it from my point of view at Royal Melbourne Hospital. But there'll be lots of parallels with hospitals all around the country. I'm sure we don't do anything particularly different to most major hospitals in Australia. Oh no, maybe that's, there we go, technology. So hemoglobinopathies comes under classical hematology at the Royal Melbourne Hospital, and it is part of clinical hematology, which encompasses both the Royal Melbourne Hospital campus and Peter MacCallum Cancer Centre across the two campuses, which are side by side, collectively known as the Victorian Comprehensive Cancer Centre. But we are not a malignant service. We deal with non-malignant hematology, and I've listed there some of the hematology conditions that we will look at. So they're treated at Royal Melbourne rather than at Peter Mac. And Kylie Mason is our lead consultant hematologist, and she's supported by a very experienced team of hematologists in the adult setting. And there's 3 clinical nurse consultants, of which I am one, but Rebecca Dring also, who has a oversight of thalassemia patients, looks after MDS patients, and helps to triage and run a very busy rapid iron clinic. And Michael Brown is our other CNC, who predominantly looks after the PNH and the Gaucher disease patients. And so my interest is in sickle cell, but I also have another title, which is a bone marrow transplant donor coordinator. So I'm involved in providing and sourcing donors for our transplant patients as well. I think I may have skipped across. So focusing on the hemoglobinopathy service, as I said, it's run by Kylie. We have a clinic once a week on a Tuesday morning, which is quite a small clinic. We try and keep the appointments down to no more than 10 if we can. And that means we can allocate a good amount of time for each of our patients. Sickle cell, as you have learned from previous presentations tonight, is a systemic disease, and so patients have complex needs and need that time to go through various issues they may have. And in that clinic we have a consultant, we have a registrar, and also a nurse. So it'll be myself, and for the thalassemia patients it will be Rebecca. Registrars rotate through the service, so it helps to train registrars in hemoglobinopathy, which hopefully they will then take that on to utilise in their careers elsewhere, and help to increase the level of expertise in this area within Australia. We are currently running a predominantly telehealth and phone clinic service at the moment because of COVID, which has been effective, but I have to say I do miss seeing people in person. It's much nicer when they can come in. But at least this way we've been able to maintain a clinic service without putting people at risk of travelling around Melbourne, which is becoming difficult these days. And this clinic has a very strong focus on preventative health. We do regular surveillance testing of organ function for our patients, and we do have an annual, biennial and up to 5-yearly sort of rotation through various tests depending on how well they're going. We now have an electronic medical record which is shared with the Royal Children's and the Royal Women's Hospital, which is fantastic. So it gives us that reach across the various campuses within our area, and on that we have a template that helps us keep on track on where patients are and what they've had done and what they need to have done. So that's been really helpful. Included in that is our vaccination schedule, and we do strongly encourage our patients to register with the spleen registry and keep up to date with their vaccines in that way, and that's a really great service that is offered through the Alfred Hospital. We do have lots of referrals to other departments our patients require, like everyone. They need input from heart doctors and kidney doctors, neurologists. We have an endocrinologist who sees our patients and helps us get bone strengthening drugs like Zometa for them if needed. They'll be referred to orthopedics if they're having vascular necrosis problems or joint problems, and respiratory physician to see them regarding pulmonary hypertension. We have a sleep medicine department which we've been referring patients to. Patients with sickle cell have an increased risk of obstructive sleep apnea, so patients who are reporting fatigue or difficulty with sleeping can benefit from that input, and sometimes they need to go onto the CPAP machines to help improve that. And then obviously we also like them to have their eyes checked and to be seen by gastroenterologists as required. So it's a busy clinic. We do a lot of referrals to other disciplines to help maintain the health of our patients. We're not experts in everything, so we do defer to our colleagues for their input. And we also run a transition service from the paediatric to adult service, which is in collaboration with the Royal Children's, and that's been really successful and a nice way to introduce patients from their lovely care that they get at the Royal Children's into the adult service, where they are hopefully going to become more empowered to look after themselves, and that's really what we're aiming for. So currently we have about 50 patients. I think I may have overlooked a couple, so my apologies to them. And our average age is 35.5 years, so quite young. And the range is from 20, and our oldest patient is 76 years old. She's just had her birthday at the beginning of June, so that's nice. And a reasonably even split between male and female, predominantly sickle cell anemia, so homozygous for sickle cell. But we do have a small group of patients with beta thalassemia, and one with sickle C disease and one with sickle D disease. And we see the majority of our patients are only ever seen in the outpatient and ambulatory care setting, so our clinic is really important. That's our only opportunity to touch base and catch up with them. And that's good. We don't want them to be in hospital. We want them out and about. As everyone else has sort of alluded to, there's obviously the ethnicity of patients does reflect the immigration of patients to Australia, and we see a similar kind of demographic that other hospitals see in regards to patient ethnicity. And, you know, if you look at your historical malaria maps, you'll see there's a very close correlation with that, as has been mentioned. So my job as a clinical nurse consultant in this population is really, I guess, a touch point between the hospital and the patient, so that I'm that point of entry. I get lots of messages and texts from patients asking me to help them with things, you know, if they need a new prescription, or something's happened and they're not sure whether they should come to hospital, or, you know, that sort of ongoing sort of life advice, you know, about general health care. Strong focus on trying to keep their education in regards to their disease, and making sure that they are empowered to look after themselves. So again, that promotion of health. We now have this electronic medical record, which is fantastic. So we're encouraging people to access their patient portal so that they can also review their results. They can keep track of their appointments, which can be numerous and challenging to keep in touch with. And they can also contact the hospital through that health hub. So that's something we've really been pushing lately. It's only just come online now. It is a lot of coordination, so coordinating treatment, appointments, prescriptions. We're trying to reduce the number of times people have to come to hospital, so we try to book appointments around, you know, other appointments, so that they sort of come in one day and get as much as they can done wherever we are able to do that. And we also provide letters to patients who are working or studying to help them get time away from work. We know this is a big challenge for the working patient, to be able to take time off on a regular basis to come into hospital and not to put their employment at risk. And we provide letters to students to help them so that they can have some consideration sometimes. You know, if they are likely to get a crisis, we know that times of exams can be a time of stress, and that can be a time of crisis. So providing documentation so that they can provide that to their university, so then they're aware of the situation and can give them some more consideration in these difficult times. We do run a red cell exchange program. We've been doing it now since 1998, and I came in at 2002, so it was the year before Shane arrived. And so I think we probably were the first hospital in Australia to start this process on a chronic exchange basis. And at that point, there was only 7 patients. We now have 36 patients who regularly come every 4 to 6 weeks for treatment. So for all you blood donors out there, we probably give about 2,000 plus units of blood a year. So we desperately need people out there to continue giving blood, but it's so important. And we found the service has worked really well. It makes people, keeps them well, keeps them out of hospital. A lot of patients haven't had a crisis which has required hospitalisation since they started red cell exchange. It doesn't work for everyone, but for a lot of patients, it's been really beneficial. Helps to allow them to just get on with their life and not be, you know, defined by their condition and limited by their condition, which we really love. We have an on-call service as well. So if someone comes in trouble in the middle of the night, we're able to provide treatment for them if that's required, and we have blood available. And we will also provide red cell exchange to patients who are being admitted with a crisis to reduce the length of stay in hospital and help to resolve that crisis as quickly as possible. We try and provide pre-operative exchanges so that there's less problems occurring during surgery because of their sickle. And we're very keen to put patients who are pregnant onto red cell exchange to maintain their health during their pregnancy for themselves and their baby. And we've had, I think now 9 babies born under our care, which has been amazing. So challenges, I guess it is looking after people who are predominantly outpatients is a kind of akin to herding cats, really. It can be quite a challenge just keeping up with people. It is difficult for people who are on long-term medication to maintain that, as Anthea said, and I certainly would struggle with that myself. So it's encouraging people to maintain that adherence to their treatment regimens and their medication and realise the benefit of it. A lot of our patients do know what happens when they stop their hydrea. They end up in ED, and that's, not the way we want them to manage their disease. It's a challenge sometimes with young adults, particularly being, having everything arranged for them when they were children, and then stepping up into the adult service and being expected to be independent, and so that can take some time to develop, and so we support them through that. And I think having a nurse as a point of contact is helpful, because they do have that person they can go to, and we really do and try to get them engaged in their own health, so that they are maintaining their health as much as they can. Challenges, I guess, in terms of managing pain, though, can be tricky, and we do try and provide alternatives to opioids where possible, because opioid medication itself can be problematic. So it's involving in the acute pain service or the chronic pain team can be really beneficial in that respect, but it is difficult when you've got patients with long-lasting chronic pain issues. We've had problems with hydrea compliance and people hesitant to take hydrea for all the reasons mentioned. So that's something we also try and to educate our patients about. And we have a reasonable success rate, but there's a lot of patients who are still very reluctant to take hydrea. And we're also finding a similar situation in terms of vaccine hesitancy in our sickle population, unfortunately, with the COVID-19 vaccination program. So really proactive in encouraging our patients to move on and get their vaccine done, and providing them documentation so they can get their vaccines. But it is difficult, and we do get concerned about some potential poorer outcomes if they don't get vaccinated. So I guess in terms of my position for future priorities, really what we want to do is to keep on improving outcomes for our patients. We want them to live to their 70s and 80s. We want them to grow old. And so we're working towards a wellness model, and with that would be a nurse practitioner role. So as I say, both myself and Rebecca are endorsed nurse practitioners, so we're hoping to step into that role soon to be able to provide that sort of service that the medical staff don't always have the time to do. And looking at developing, standard individualised care plans for pain management with a nurse practitioner from our acute pain service at Royal Melbourne, in collaboration with patients, to make sure that we're able to meet their individual needs if they do present to ED. And hopefully some research opportunities in the future in terms of nurse-led research, but we're also hoping to get a fellow to help drive research in this area as well, because there's so much more that we need to do to help improve outcomes for our patients. So thank you.
Thank you so much, Claire. Thank you so much for that very informative session. We're stopping to share screen.
Yeah, I'm trying.
maybe I'll try from here. I just want to, let's see, yes. I have to sort of share and then stop. That's the only way I know how.
That's it. Thank you.
Yeah. Again, I so apologize. I saw Anne Duncan quickly before we go now, summing up everything together, just how all this works us in our emotions. How do we take care of ourselves? We have Melody, who's the mental health expert, but I want to recognize Anne Duncan. Anne Duncan is a clinical nurse specialist at the Royal Children's Hospital. She works with Dr. Anthea Greenway. She was supposed to be on the panel to replace Dr. Pascal Barbara, but I didn't see her. Anne, are you there? Just want to quickly say hi. I don't know whether you're there, Anne.
Yeah, I am, Agnes. I won't put my camera on because I'm at home, but I am here.
Okay.
So it's been a very enjoyable evening.
So sorry that I didn't see you before. I would have loved you to join Dr. Greenway's panel, but we'll talk offline how we can work together again. So Melody's a nurse, is a clinical, she's a mental health expert, sorry. She'll just sum it together why we are doing this, why we talk about health. And Melody, you can take it over, please. Thank you. Melody, are you there? You are mute.
Yes, I'm trying to share my screen, Agnes. Just give me time.
Okay, thank you.
Yeah.
Maybe while she's doing that, Anne, do you want to just say 1 minute? Anything at the Royal Children's?
Oh, am I off mute now?
Yes, yes.
Can you hear me now?
Yes, please.
Yeah, well, I don't think I've got sort of much to add. I just sort of working with Dr. Greenway at the Children's, and like Claire, it's sort of a real collaborative approach across the medical and the nursing teams, which I think works really well. And I think, yeah, just continuing sort of to focus on health promotion and overcoming the barriers that have been outlined is a really good way of moving forward for this population. I think it's great that it's getting a lot of you know, traction within the healthcare service, and the more people with the awareness and sort of interest in this specialist area, the better.
Thank you. Thank you so much, Anna. Melody, please go ahead. Thank you so much.
Oh, thank you so much, Agnes. Hi, everyone. I'll try to be as quick as I can, as I know that we are all running behind time. I would just probably just flick through, to be honest, because of time, but I've been asked to talk about mental health, which we all know is it's quite a big topic, so I will try to make it as quick as I can. And Agnes has asked me to talk about mental health and in relation to stress and how we cope with it, given that we are living with chronic illnesses and what it is that comes with that, and how are we coping with that in order. And I heard, was it Natalia that was talking, Natalie, that was talking about, you know, life has to go on regardless of what we have. And I always think that, yes, we've got an illness, but there's a human being alongside the illness. So if we can still be able to live our life to our potential, regardless of the illness that we've got. And of course, coming from a mental health background, I'm a registered mental health nurse, been practicing for about 15 years. And I'm also a DBT therapist, and I'm an advocate for mental health within our African community, and I run a talk show. Yes, and so I do outreach mental health for our communities. So thank you, Agnes. And I guess, yeah, we know what stress, when I guess, just briefly describe what mental health is. And then according to the WHO definition, they are saying it is a state of well-being in which an individual realizes his or her own ability and can cope with normal stresses of life, and also can work productively, fruitfully, and is able to make a contribution to his or her own community. And I think that's where we're thinking it is important that even though we are living with loved ones who have sickle cell, and or we have it ourselves, how then do we look after our mental health alongside our physical health? And now I've always said, you know, mental health is as important as your physical health. So just as much as we need to be healthy and making sure that we're going for our appointments, you know, in terms of, we heard the discussion right from the start, getting donors, making sure you have got appointments, you know, the transition from peds to adult and all that. So we are making sure we're looking after our physical health, but where is the mental health there? Because for us to be able to run around and be able to attend all these appointments and looking after our loved ones or living with the sickle cell disease, we need to be able to, we need to make sure that we have a sound mental health. And so that's why I always say, when we say let's exercise, let's do this, let's eat healthy, what are we also doing for our mental health? And then, of course, there is a mental illness, which, of course, we know what that is. It's medically diagnosed, because people mostly use these interchangeably in the wrong way, where we say mental health, just like physical health. Everybody has mental health, but a mental illness is where it has now been diagnosed. That's just like a physical health, where we've got a sickle cell disease, we've now been diagnosed. So that's the difference there, where a mental illness is actually medically diagnosed and can result in significant impairment. And the reason why we're talking about and giving a background is that we can get an understanding as well that if we don't look after that, you know, that's where also we have stress. And if you don't look after or take care or cope with stress, it may lead to long-term mental illnesses as well. And then, of course, we've got defining stress. I think we all know stress. It is, it is how the bodies react to any changes that required an adjustment or response. And I guess the body reacts to these changes, in different ways, sometimes physically, mentally, and emotionally. I think I heard, was it one of the speakers there saying, I've had some emotional stuff going on, and I needed a shoulder to cry on. So these are some of, and I think Dilly also did talk about, those emotional stuff. So we need to be able to know how to respond to those and how to cope when we have those. And these are very normal. We all go through normal stresses in life, but it's about how each and every one of us, accept that and interpret that. And that determines how we respond, or we adapt to it. So it's either there is that the body's natural defense against real or imagined danger. So yeah, so this is the known the fight or freeze response to stress, which I think we are all quite common with. Now, it is an event or a circumstance that's the stressor. So stress usually comes along when we have been subjected, or there has been an event or a circumstance that has caused stress, and that's what we call the stressor. So here we are talking, when we talk about living with sickle cell disease, SCD, we find that if we are not able to acknowledge that and accept that this is the reality of what we've got, and and I'm taking practical steps, treatment and everything to get things right, and then accepting that these are things that I'm living with. There are certain things you can change, and there are certain things that you can't change. And so it's about accepting that. So that thing that causes stress is the stressor, and doesn't, so I guess that's what I wanted to just say. So is stress a mental health problem? Others would ask. It's not a psychiatric, it isn't psychiatrically diagnosed, but it is very closely linked to your mental health in two ways, and I'll try to quickly just explain. And so stress can cause mental health problems, right? So if we don't cope with stress well, that can lead to mental health problems later in life. So for example, if you often struggle to manage feelings of stress, or you might develop a mental health problems like anxiety and depression. So that's why it is important for us to deal. And also, mental health problems can cause stress, and also physical. You find when we go on later, we'll talk about, some of the risk factors or causes of stress also are related to our physical health. So there are different types of stresses out there. We have what we call acute stress, and this is usually brief, very brief, and it is most common and very frequent presentation. And this acute stress is most caused by our reactive thinking, and mostly, like, for example, we had Dilly, I think, talking about how she first discovered that this was what was going on for baby, and that immediate response to that, it caused a lot of acute stress for her until she managed to get help and support and started to kind of come to terms and kind of deal with what was going on for her and reflect on that. So that's acute stress. And so negative thoughts predominantly about situations of it that have recently an upcoming event or something like that. Also, acute stress can cause causes signs and symptoms in the body and the brain. So you will find that if we do not deal with this acute stress, it then kind of leads to what we call episodic stress, and then to chronic stress. So it's kind of a series. So there's that acute, and start building up, then it may end up causing some mental health problems in the long run. And that's why it is important that when we are living with some physical health challenges, it is important, and I heard this in the panelists, that the guest speakers were talking about, how everybody is working as a community in order to help us understand, this, the treatment and how best we can support each other. And that's part of what I guess Agnes and her team are doing here, that awareness and reaching out and making everyone feel connected, that will kind of help the people as well. So I'll continue with that. So the type of the episodic stress, this one is people who frequently experience acute stress, right? Whose lives present with frequent triggers and stresses, have this kind of stress. And there are two types in that. So there's a type A personality, which where an individual has got an excessive kind of competitive drive, and comes with some underlying aggressiveness in there, some impatience, abruptness, and that's just the sense of urgency, and I think depending on where we are at in terms of our lives, our physical health and everything else. And I guess I'm trying to pair this or marry this with living with sickle cell disease, but this can be with anything at all, a child that has it. And as a caregiver, how are you managing that? Where you want things to be done as per yesterday. Why can't it just be over, and so you end up with this sense of urgency. Everything has to be done as per yesterday because you just don't feel you have the time. So that's how sometimes it can present. So that's episodic, and it comes and goes. It comes in phases depending on where you are at in your life. And then, so this type A personality presents with a reactive or hostility and, a kind of a deep seated insecurity about performance. And you find this probably even in the children that we are caring for at home, or relatives, or in the community, people that you are working with, right? I'll quickly rush towards that. So if we don't deal with these types of episodic stress, sometimes we may end up most likely developing other diseases like coronary heart disease, because you're putting your stress on yourself. And then there's what we call the warrior, and usually more to do with weather and stuff. So yeah. Okay. Then we have, and this can also develop, I guess, when you've got, and I guess some of you here could relate, where even as children, and I heard that there is a good support, genetic counseling that's going on here, which is really good, because having that illness as a child, I don't know, because I've not lived that, and I don't know how that would affect the child. So it is important that we give them the support in order to understand what they are living with, so that's quite important as well. And then of course we've got the chronic stress, which it is the most harmful one if left untreated. And I guess different from acute, where the stress that's caused the acute stress, sometimes if it is resolved and you cope with it and you deal with it the right way, you get enough help, that will go away, and you will continue to live your life meaningfully. But with the chronic one, this is the most harmful. Like the saying, if it goes untreated for a long time, it can significantly and often is irreversible and can cause a physical and a deterioration in your mental health. So it is important that we get support and get strategies on how to deal with this kind of stress. And some of the risk factors, of course, stress factors anyone and everyone, but mostly childhood experiences, personality, genetics, like we heard here, and also immune-related diseases. And some of the causes of stress can be external, and some of them can be internal. So, external, like major life events where, you've got gone and given birth to your baby, and you realize that, okay, this is what is going on. So that can cause stress. And so that's why we need to acknowledge and realize, know the symptoms, and then get support for it. And that would help us a long way. Work, of course, relationship difficulties, and having had looking after a child or being a caregiver, everyone within the community or in the family or within your circles, also they need also to be able to understand you know, the illness that is going through the family in order to support one another and hold each other's hand and have a shoulder to cry on, like someone was saying. So yes, relationship difficulties. So if in the family people are not aware of what this is and how to deal with this and how to cope with this, that can also cause major stresses where husband and wife are not at the same page in terms of, okay, how do we define this illness and how are we going to move forward? What help are we going to get? What connection do we have here? Who's here to help us? That can cause a lot of stress on caregivers as well as other family members in general, and even the children. So yeah, and then there's of course the internal stress factor cause, which is the inability to accept the unaccepted. You know, this is what it is. The child or myself, I've been diagnosed with this illness. I've got to accept it because it is painful, but the pain of not accepting reality is much more painful. So you would need that support in order to be able to accept the things that you can't change. Yes, this is what it is, but what I can change is how I can look at life differently, living alongside my illness. And also being quite pessimist and negative self-talk sometimes can really lead us to, oh, I've got sickle cell, so life is going to be hard. I can't do this. I'm not going to be able to achieve anything in life. So we need to start to talk positively. I heard one of the speakers here talking about how important it is to start to look forward and be quite positive. Yes, this is what we've got, but there's still life ahead of us. So how do we get that going? So unrealistic expectations. It's also good to understand where you are with your illness and what you need to do. It's one step at a time to get to where we want to, or how to achieve our goals. That way it causes less stress for you. And then of course, lack of assertiveness. And of course, this is just graph that I got, which causes of stress, personal lives, 20% really is juggling work and personal lives. I heard, I think, was it Mwea Chisenga? She was talking about how she had to juggle, you know, going to appointments, coming back and all that. So you find if you're not able to cope with that and you don't have enough skills to do that, that can become quite stressful. So hence we need to be aware that 20%, it takes about 20% of that. And then of course, 28% is about people's issues. And of course, 46 is life workload and lack of job insecurity, which is probably, symptoms. And I guess lack of job insecurity, what I would like to say this is, it's good that, you know, when you've got or you're a caregiver of someone with a chronic illness, it is important, you know, to be financially stable and know that you are going to be supported financially, because like we're saying, lack of job insecurity, you don't have a job and there's less income coming in, that might also raise stress levels for you, and that would impact on how you're going to care for your child. So that's important to also just take note. And these are some of the signs that we would see to someone who's presenting with stress, high stress levels. It does affect our body, our mind, our emotions, and our body. And when we are in cognitive therapy, we talk about how it is a kind of, you know, from a negative point of view, it's a vicious cycle, and how you can turn that into a victorious cycle. You know, a situation, the stress is right in front of you there, but how you respond to it, you know, affects your body, how your body responds to it, and then your behavior, and then of course your emotions, and it keeps going like that. So they are all interconnected. And I will not go through the list, but I can put the slideshow to Agnes if you guys want it. And then of course, identifying stress, like we said, stress is not always easy to recognize, but there are some ways to identify some of the signs. And, you know, so sometimes stress can come from an obvious source, but sometimes even small daily stress from work, school, family, those things, they can actually take a toll on your mind and body. So some of these strategies we would do on how to cope is, you know, getting connected at a family level. You know, family can act as a first support for the individual, right? You know, children model their parents' behavior, including how we also relate to stress. It's amazing how children children see, children copy. So they see and they do. So it's important that even as caregivers, when we are looking after our young people who have the sickle cell disease or any other chronic disease, to be aware on how we are responding to the stressors around us, because that can also impact on the young person that is experiencing a chronic illness. Having regular conversations is quite helpful as a family together. You know, the family that is together, stay to have those family meals together, talk about your experiences at school, just talk about these things. It's okay to talk. It's okay to say I'm not okay. So over a meal at the table, when you come back, have enough time as a family to just check in on each other, right? And then of course, community level. And I guess this is what part of is happening here with Agnes and her team. You know, they are building and you know, and making people feel accepted and belonging regardless of the physical challenges that they might be going through in life, and you know, setting goals, you know, and trusting and getting connected. So that's how we can help also to deal with stress. And of course, there's a part that you also need to do as an individual, and that's looking after yourself. I always call looking after number one, which is yourself. And so, you know, check what kind of music you like and all that. So that's all there. Nature, yoga, you meditate, you know, your hobbies, you exercise. We cannot stress that enough. You know, go and have a bit of massage, you know, spa time management, all that. That's another way of coping and dealing with stress at an individual level. And of course, you know, keeping a positive attitude, finally, accepting that the events that you cannot control, and being assertive instead of aggressive and all that. And of course, making time, interest in hobbies, and of course, seek out social support, spend enough time with those that love you and those that you love. And of course, yeah, and I think that's what I had. And yeah, if anyone is needing support, we have our helpline, Beyond Blue. We've got the, you know, other websites available on request. If Agnes wants those, I'm happy to email them. I've got them. I've got a slideshow on all those and where you can get help. So no, thank you so much. And I'll leave this time to Agnes. I'm sorry I had to rush through because of time. Thank you.
Oh, thank you so much, Melody. I'm the one to apologize. We overlooked our time, but thank you so much for the presentation. We are coming right to the end of our session. Thank you so much for staying on. And at this point, Isabella just wanted to say a vote of thanks. Isabella.
Hello, everyone. Can you hear me?
Yes, yes.
Okay, good, because I have different headphones on today, so I wasn't quite sure. Thanks to all the speakers out there. I've been doing this for a long time, and all the information that has been presented was quite informative. So I do appreciate everyone's presentations tonight. They were a good reminder of what needs to be done for the care of those that have sickle cell disease. I'd also like to thank the introduction of the mental health talks that were just being discussed just then. The importance of that, Melody, is really has been missed, I think, and only coming through in the past, I'd say, in the past few years, where they find the importance of mental health to also be part of the care for those that have sickle cell disease. There's so much involved, as the clinical nurse had said before, that there's so many tests that you need to do to make sure that the patient is okay. Mental health should also be part of that. So I thank you, Melody, for that presentation. That was very important. And hope we can share that throughout the communities around Australia. I myself am from Queensland, and I have 2 children. They were diagnosed in Victoria when they were very young. Shane, I remember the reason that we moved up here to Queensland was because of the weather also. My son is treated there at the Gold Coast University, Hospital, and my daughter's is treated at the Mater Hospital. All the medical staff are very good in looking after my adult children who do look after themselves and have taken responsibility for their care, which is actually very good. And they do call upon my help every now and again just to say, hey, Mum, I'm not quite sure about this. Can you help me out? And of course, I try to with their care. So thank you to all those medical health care people that do look after our children, from young adults, young children right up to young adult lives. And to all the blood donors out there, my son does do apheresis. He actually had his treatment yesterday as well, Shane. So I don't know if you cross paths. There's a lot of blood donors out there, and we have to be mindful that someone pointed out before that we are a very multicultural group. My background is Italian and my husband's Maltese. And as you can see in this group right here, we are from all different parts of the world that need care. So that means we all need people from all the parts from our cultural groups to start donating blood to make sure that our children can live a pretty much normal life. I thank all the blood donors in the past 30 years that have been providing that liquid gold, basically, to make sure that my kids survive and are able to, live the life that they've been gifted to live all these years. So thank you. I really appreciate that. Agnes, good on you for starting this. Couldn't do this without you. It's so important. A big round of applause for this lady, because she's done this for a very long time. So yes, big clap. I should be looking at the camera here. I'm looking at my screen over there. I'm looking in the wrong direction. Maybe I should put this down. Yeah.
We're a big, lovely team, and we work so well together. So all of us, it's a team effort. Volunteers.
Well, it is, but I think that it's you that's brought us all together, and it's your passion that's reignited my passion about advocacy. And I thank you for that, and I'm sure everyone else does too. And I know that many, about, let's just say 27 years ago, when my daughter was first diagnosed, we felt very alone, because it's very different living a life with sickle cell than it was with thalassemia. They have sickle cell beta thalassemia, but they present as a sickle cell patient. So thank you for reigniting that in me, and to want to be helping all these young people like Dillis, who has that little beautiful baby boy, and knowing that, there's someone out there that they can actually turn to. So thank you for that. And that's it for me. That's it for me.
Wow, thank you so much, everyone. Again, I'm so sorry. It's just so, I don't know what to say. Thank you so much again. We are thankful for what you do, clinicians and other volunteers. Maggie, we can't do this without you, and everyone who has left. Melody, everyone, thank you so much for this. And we continue with our World Sickle Cell Day events. We'll tell you what we're doing next. So good night, everyone. And I'm so sorry again.
Oh, thank you so much. You've done a great job. Don't apologize. Thank you so much.
Absolutely.
Yes.
Yeah, absolutely.
Thank you, everyone.
Thank
Good
you.
night, everyone.
Thank
Good
you.
night. Good night.
Good
Thank
night.
you.
Good night.
Good night.
Good night.
Next week, Blood Donor Week. So yeah.
Each week.
Thanks, everyone.
Good night. Good night.
Thank you. Good night.
Bye, everyone.